Just need one.
Okay, let me know when you're ready and we're ready.
There might be an echo for about 2 seconds.
Okay.
All right. Streaming, let me just share my screen, I'll share the presentation.
Co-chairs, take it away, please.
Okay.
Thank you.
Hi, everyone, and welcome. My name is Queenie Hewling. I'm the co-chair, and my colleague.
Hello, how y'all doing? My name is Amaryllis Herrera. Everybody call me Angie. I'm the co-chair of the Health Committee.
We want to thank you for attending this meeting and to let you know that your presence is highly appreciated. Tonight, we have two guest speakers from the Jewish Community Council of Greater Coney Island Trauma Recovery Center. Dr. Forgive me if I mispronounced your name. Dr. Dulan, okay.
Thank you.
And Dr. Alex Lodge?
Just Alexis Lodge, yeah.
Okay, Alexis.
Not yet.
Okay. They will give us a general interview of the TRC model and the work the center is doing in Coney Island community through a brief presentation. All yours.
Oh, thank you. Well, good afternoon, everyone. My name is Dulan Louis. Some people call me Dr. Louis. I am really just Dulan out here trying to help the community the best way I possibly can. As the co-chair stated, we will talk to you briefly about the Trauma Recovery Center model, but we will talk specifically about the work that we are doing in the community using the model, ensuring that we meet the needs of the individuals we serve in the community. With me, I have my colleague, Alexis. She is also a licensed social work practitioner. She too loves the work that we do together, and we are really a great team together. So first, as I stated, we will give you a very high-level overview about the Trauma Recovery Center, the model itself, and how we are ensuring adherence to the model fidelity, and the work that we do in the community. This agenda, next slide, please. This agenda will inform our conversation, but I just want to give you some context. We are part of JCC-GCI. We are I would say, the newest program of JCC-GCI, and we are one of 4 trauma recovery centers in New York City. I will turn it over to my colleague, Alexis, to introduce herself, and together we will navigate the PowerPoint presentation.
Hi, good evening, everybody. I'm Alexis. I am a social worker. As Dr. Louis shared, I call her Dr. Louis because she's my colleague and I have such a great respect for her. I'm a social worker. I live in Brooklyn. I live in Midwood. Very, very excited to be here to serve the community and I'll take you through a few of our points about our program and what we do. Slide, please. Slide, please. So we are the Trauma Recovery Center. We follow the trauma recovery model. That model recognizes that the most harmed are the least helped. Okay, and our goal is to remove those barriers to care, and we try to transform, the service that survivors of violent crime are receiving. I'm going to talk to you about a few of the ways that we do that are different from what you are typically accustomed to in therapy, okay? Just some data, okay, on why the TRC. As you can see here, first of all, the TRC model is originated from California. It was born in California, and that's where we're going to see the highest concentrations of TRCs at this time. But right now, the data that we're seeing from California and some other states are about 20% of crime survivors were aware of victim restitution funds. And I can tell you firsthand in my experience with people who are eligible for those funds, they are not aware.
Next slide, please.
Oh, I'm so sorry. Okay. Okay, so the National again, those are the statistics I was just mentioning here. Only 4% of survivors' needs are typically addressed by the current victim services system. And I don't have to tell anybody in this room that ethnic and racial minorities typically have the highest unmet needs, and we're here to try to stand in that gap. Slide, please. So here's some of the economic consequences of violence. We know that untreated trauma results in a higher likelihood and high risk behaviors, stuff that you guys are seeing out in the community, the smoking, alcohol, substance use, the poor diet and exercise, which is contributing to so many of those comorbidities, okay? The survivors of violence are often, 2 to 2.5 times more frequently than those without a history of violence. They're accessing care that much more frequently, 2 to 2.5 more times, which is costing us well over $300 to $750 billion annually. So, politicians and folks like that, they like to tie into money and numbers. And that's what's really important here, is that we can definitely address some of these economic consequences. 17 to 37% of the total healthcare dollars are spent on those chronic medical conditions that are consequences of untreated trauma, right? So that stress pileup and all of those symptoms that come subsequent to that are contributing to all of those other comorbidities.
What I want to add here before we transition to the next slide is untreated trauma is very expensive. Expensive not only on the community we serve, but also expensive to the healthcare system in general. What do I mean by that? As my colleague just explained, when individuals are dealing with unprocessed traumatic experiences that they haven't had an opportunity to process, recover, and grow from, those experiences lead to comorbid conditions such as hypertension, such as type 2 diabetes. Chronic stress is one of the major criteria for everything that we're seeing in the healthcare system. And because individuals do not receive the timely services that they need, the effective services that they need, those chronic stress, those stressors lead to comorbid condition, as I stated, such as type 2 diabetes and hypertension, which is extremely expensive, not only for the individual, the family, the community, but for the healthcare system at large. And the Trauma Recovery Center comes in, provide those services promptly and effectively. And when individuals are actually able to recover, heal, and thrive, irrespective of those traumatic experiences, there is a high possibility for them not to experience those comorbid conditions we talked about. And that is really one of the values of the Trauma Recovery Center. Next slide, please.
Okay, so like I kind of just mentioned, the first Trauma Recovery Center was developed at the University of California, San Francisco in 2001. The goal was really to provide a one-stop shop for survivors of violent crimes throughout their recovery process. The goal being to be as close to the immediate aftermath of the trauma as possible, but we understand with community violence and just trauma in general, that's not always realistic or possible. So we're here at any time for a survivor of trauma or violent crime, but certainly we would like to get there as soon as possible. We, of course, provide, confidential services within the community. And I'll talk to you a little bit more further about what that looks like when I say in the community.
Next slide, please.
Okay, so like I mentioned earlier, the traditional psychotherapy model is typically office-based. Okay, there's no home visits. You are going to come in, you're going to talk about your feelings and what's going on internally in the office with your therapist. There's not going to be any other coordination of care with any other providers or anything else that's going on. Typically, you're going to get, anywhere from 45 to 55 minutes in your hour. And it's very, very emotive driven and psychodynamic. And that's kind of the parameters for traditional psychotherapy. We vary from that slightly. Sorry. The way that we vary for that is that we have this innovative model that blends comprehensive care, advocacy, and outreach. One of the great things about the trauma recovery model is that although we here are social workers, it's an interdisciplinary model that all types of providers can serve within. We meet the participant where they are. What do I mean by that? I've literally had sessions on this boardwalk. I've had sessions in libraries. I've had sessions in people's homes. I've had sessions on Zoom. I've had sessions in my office. And as recently as today, I actually worked in the community. I did a whole day working in the community. And so our goal is to bridge that gap. People who are experiencing these traumas may not be well enough to come to the therapist's office. And so the goal is to bridge that gap, whether that's virtual, whether it's me coming to your home, whether that's we're meeting outside and going for a walk, whatever that environment is, that we can meet those needs. Additionally, the trauma therapist is also providing a full spectrum of comprehensive clinical case management. What does that mean? If you're coming to me, you have experienced domestic violence or you have been assaulted in the community and you're coming here to process that trauma, but additionally, you don't have enough food to eat at home, you're housing insecure, your social security is something that's going wrong with it, you need recertification for Section 8. That's also something that I, as a trauma therapist, will do. I'm not going to send you to somebody else. I'm going to work on that, and that prevents things from slipping through the cracks. That prevents miscommunication, or, you know, somebody didn't follow up on that. And that's what makes it really unique. I can go to you and I can do more than just talk to you about what happened or your feelings. And that's what makes this model really unique. Dr. Louie?
Yes, I'll give you a tangible example. Let's say my son, hypothetically, was shot and killed 2 blocks away. And someone referred me to the Trauma Recovery Center to receive services. But the person is focusing primarily on my psychological and emotional well-being, right? Because my son was shot and killed. I'm grieving. As a mother, I'm grieving really hard, and I am not able to cope. Now, once I enter the office, the very first thing that will happen typically under the traditional way of providing services, the therapist will assist me in processing my grief. The therapist will help me to understand how I can cope effectively, validate what's coming up for me. Now, the Trauma Recovery Center model is different because we understand that whether or not you are still navigating the grief, right? As a mother, the grief is hard. Your son was murdered, right? But if you don't know where your next meal is coming from, you don't care to process the grief. You have other children in the home who you are not able to feed. So your primary goal is to be able to feed those children you still have at home. And once that is taken care of, then you can start to sit with your emotions and process the grief for that child whom you have lost. If you do not know exactly where you're going to lay your head because you're moving from one family member's home to the next family member's home, you don't care to process the grief because you are in survival mode. So we understand that, which is why we work with individuals based on their needs. I know what the needs are, but you get to tell me exactly what you need to work on first. And we are patient with individuals, as my colleague stated. If housing insecurity is what is pressing for you in the moment, we can postpone the processing of the traumatic experience, and we lead you to shelter. We lead you to ways in which you can obtain and maintain secure housing. If food insecurity is the pressing issue, we help you to deal with that. So then once that is in place, you can actually sit with the traumatic experience and get to process that. It's a very holistic way of providing services. The best way we can talk about it is a one-stop shop.
Yeah.
You get your therapeutic services, but you also get your practical needs met based on what's happening in your life at that very specific time. Now, it doesn't mean that when you go to JCC-GCI, you're going to have a physician, you're going to have someone in the office to help you to process your food stamp application or your Medicaid application. It simply means that we connect with individuals, with entities, with service providers in the community while we are assisting you in processing the traumatic experiences. So we believe in linkage. Linkage is a primary factor of the work that we do. We don't have those individuals on site, but we are resourceful. We know where to locate those services that you need. And not only we identify those services, we give you the referrals, but we remain in close contact communication with those individuals so that we understand how you're navigating those needs, whether or not you are getting those needs met. And if we need to intervene, we will certainly do that because we believe in ensuring that we give people exactly what they need as we're helping them to process their traumatic experiences. And if you have any questions as we're going over the information, please feel free to stop us. Next
Let me
slide,
ask you
please.
something. I'm just curious. Like, how do you get the people, because that has to be very challenging to get them to come in to actually talk about trauma and very personal things that people probably never talked about before.
Actually, it's not. And that's the myth, right? Because we believe that it's quite challenging for people to talk about what's happening for them.
Mhm.
But once you start engaging with people from a very humanistic perspective, everybody wants to be seen and heard and understood. And we start the intake process with a great deal of intentionality. We see you, we hear you, and we're intentional in understanding your experience from your perspective. Not every parent who lost a child through gun violence will experience the grief the exact same way.
Mhm.
We give you an opportunity to tell your story, to tell your narrative, and you'll be surprised. And my colleague will talk about that, how people we typically tend to believe that are not comfortable speaking about things private with strangers. Once you create that safe space, that brave space, that holding environment, people are eager to talk to us about their problems because we're perhaps one of the very few people who are actually willing to see them, to hear them, and to understand what they are going through.
Now, let me ask you something. Let's say, I'm just putting a scenario. There's a shooting in Coney Island, somebody gets killed. Would you go out and reach out to the family or something like that?
We do.
Yeah.
We do. Once we are made aware of the incidents, we ask if the family is comfortable with you providing their contact information to us. And once you have their buy-in, their consent, you give us the contact information. We'll give them a moment to just breathe and we reach out. And when we reach originally, we don't reach out to offer services. We reach out to offer support. And as the individuals are navigating the process, when they're ready, they actually reach out to us. We have a family in the community right now. We are constantly reaching out to every week. So the information was given to us. The person, Alexis, help me here. What is the story? The person's daughter was murdered by the boyfriend.
Yes.
And you are probably aware of that incident because it happened here in Coney Island. So we received the referral to reach out to the mother who's grieving extremely, extremely hard. Not only she's grieving the loss of her daughter, but she is also the primary caretaker of those children because the boyfriend is now incarcerated. We reach out every week, offer an opportunity to come in and sit with us. After the third attempt, we realized that's not what she needs. So we quickly changed gears and now we check in with her every week, see how she's doing, offer to meet with her for lunch in the community. Every time we offered that, she declined. But every time we call her, we ask for permission to call her again. Because our primary focus is to make sure that the person is well, not to push her into services. And once you show up consistently for people, you show up in a way that builds that level of trust. When people are ready, they know where to come to receive services. Does that answer your question? That was a lengthy answer to your question.
I just add something very briefly as well. I think to be just incredibly direct, one of my most consistent proactive participants is a Black man in his 30s. And if my appointment with him is at 1 o'clock, 12:58, I have a text message, where are you? I'm here, I'm logged in, or whatever the case may be. And that, even for me, even living in this body and doing this work, I had the bias that it's really hard to tap into Black men, especially in mental health. It is hard sometimes to get the buy-in, but if you are consistent, if you show up as yourself, if you show up with a level of understanding and a commitment to the work, they're ready and they want the help. And so it's really radically shifted the bias that I had, that we always talk about barriers to access, specifically in the Black and Brown communities, and we talk about stigma. The stigma is there is a barrier to access, but outside of that, there's a ton of people who want the help and are super ready to engage. So that's been my experience.
If I might, two things that I'm hearing here, which is really, really, really good, is that we tend to, when a crisis hits us, we have family, younger kids, relatives, it doesn't make a difference. We tend to shift into a survival mode to help them and very seldom reach out to help ourselves. And then it becomes like a domino effect because keep pushing it to the side until another event happens, or sometimes even a pin drops and it activates in that situation. So the fact that it's a one stop allows the person to, if they're not looking for counseling, but they just want to talk to someone to find out, how do I go to the next level of, say, food support or health support, that now they can also be kind of redirected but still get the assistance.
Absolutely, absolutely. And I cannot agree more with the comment you just made in terms of when we are trying to survive, we don't have time to feel, right? And sometimes we intentionally do so that we will not feel. Because feeling is heavy, feeling is expensive emotionally, right? But just because I'm not feeling doesn't mean the feeling is not there. So I'm not creating a space for my feelings to emerge, but the feelings are there. And when we keep suppressing our feelings and our emotions, emotions are bodily experience, right? So when we keep suppressing our feelings and our emotions, they show up in places that we will not typically want them to show up, right?
Absolutely.
Because they have to be expressed. And we bring people in, we meet you exactly where, if you believe food is the issue at this time, we will help you to navigate that problem, but we will remain consistent. We will certainly remain empathetic. We will adapt the notion of cultural humility, which is, you don't have to be worried about the term. It's very loaded. It simply means that we see you for who you are, and we meet the needs in a way that you tell us you want those needs to be met. And when you are able to do that for individuals, the level of connection is something that is priceless. People keep coming back.
Also, one more thing, if I may. Meeting at someone's choice of location opens up the door of opportunity to receive the counseling, because people are on a schedule, and sometimes to get to the office is 15 minutes. You only have an hour. Some people only have a half an hour for lunch. But to meet at a location with them it's an open door, and it offers the opportunity to at least hold a 15-20 minute conversation.
Absolutely.
So I commend you on going outside of.
Absolutely. We do home visits. We meet with people wherever they want to be met.
So
Because the
telephone,
whatever it is, we avoid telephone sessions simply because I don't get to see you. I don't get to ensure safety, and I don't know who's in the background listening to you. Now, phone conversation is really the last resort, but if that's the only option we have, we will explore that option.
Or maybe like video chat and stuff like that.
Absolutely. We do a lot of Zoom calls with participants. As long as they have access, we definitely feel that as an option.
And I just want to add very briefly, sometimes that is the safest option. Sometimes that is safety is always paramount. And we, with some participants, we try to bring them in person. And through our assessment, that was not the safest option. And so we have people that we meet on their lunch break on Zoom, or whatever the case may be.
Absolutely. Next slide, please. I appreciate this engagement. We didn't come here to lecture you. We come here to talk to you, and we're doing exactly that.
So we have the non-siloed approach to survivor services. That's what we're talking about in terms of working with each other, working with other professionals, working with whether it's the primary care, whether it's their physical therapist, whatever the case may be. On the screen, what you're seeing is basically some of our eligibility criteria, okay, whether that's physical assault, whether you've lost a loved one or a friend to a homicide, domestic violence, interpersonal violence, hate crimes, sexual assault, immigration traumas, things like criminal car accidents, hit and runs. People don't think of all of the various ways that trauma can show up. And the one I'm going to call your attention to is the community violence. Our goal here, as you can see, we have very specific eligibility criteria. The reason that we also have the community violence eligibility criteria is because we understand that everything is not going to fit cookie cutter into one of these categories, right? And so our goal is to respond in the immediate aftermath of the trauma if necessary. So that's what our assessment and our intake purpose is for, to see if we're able to really effectively respond to that. So I just want to be very clear about that. Just because you don't see something cookie cutter on the screen or on the slide or on our handout, please don't think that means that they do not necessarily qualify for our services. Please reach out to us, have a discussion, and we can kind of go from there.
Can the individuals on the Zoom hear us okay? I just want to make sure.
The owl is the microphone, so you're definitely.
Okay, all right, wonderful. Any questions about eligibility criteria?
Is this what you're looking for the criteria? I know it's that you have other options also too.
Yes,
But these are some of the big highlights that we have.
Cause I don't see it in the handout. Maybe later on we can go over a little bit and figure.
Absolutely.
Okay.
We have the one pager, which gives you a very concise, high level overview, and we also have the flyer. So
Thank you.
the key thing that I want to reiterate here is the notion of community units, right? So when we're talking about providing services to survivors of traumas and violent crime, we are talking about those negative, those adverse incidences that have happened in the community unit. As my colleague stated, this is not an all-inclusive list by any means. If you know someone in the community who has dealt with some very severe traumatic experiences, send that information over to us with the person's consent, of course, and we will be intentional in the intake assessment process. If the person is eligible, we will definitely make sure we provide services. Our goal is not to leave a single person behind, although we are very small. The program is going really fast, but we currently do have a wait list. So it's okay to send people our way, even if we are not able to provide services at the moment, but we will keep that specific individual in mind. And maybe that will be an opportunity for us to advocate for a way in which we can hire more individuals to render those services.
May I answer? I'm sorry, Queenie, you wanna go?
Are you part of Operation Hood?
Operation Hood is one of the programs on the JCCGCI. So it is really a sister program, if you wanna say that from
Kind of
that
work
gender
hand in-
perspective.
yeah.
Absolutely, absolutely. And we receive referrals from them as well.
In addition to some of the criteria that you have listed, when you say to be eligible, are we looking at the financial aspect of it, or it's just the issues that lay at hand?
Just the problem because our services are free of charge to our participants.
Just want to throw that out.
Free,
there so everybody
yeah.
can see.
Yeah.
It's
And
free
free, and
with a capital F.
free. And we don't even take an insurance card, but what I really want us to highlight about that part is at the beginning of the slide where we talk about the most harmed or the least helped. Those are really who we're looking for. We're not necessarily looking to help people who might have great insurance and a fantastic therapist already. We're looking for people who do not have access to these things, don't know how to access these things, otherwise would not be able to access these types of services. So certainly, yes, anybody can come, but we're really here focused on the people who need us.
Yeah, by that we
Very
mean
good.
marginalized people.
Yes, people who look like us in the room.
Marginalized people with limited access to
Yeah.
resources. Next slide, please.
So our vision is really the emphasis on assertive outreach and engagement. I just want to make a quick point about that. When we say assertive outreach, we're talking about referrals coming in. They may come in from you guys. An example of that might be you refer somebody to me. We reach out, they decided like to come in and talk with us. Maybe they come in once, twice. Week 3, I can't find them. The phone is not even straight to voicemail. It's, the number you've reached is not in service. I can't spell anything like that. I'm coming back to the referral source to say, hey, you sent me, Mr. So-and-so, and I haven't been able to find Mr. So-and-so. Can you help me? I've literally had referral sources bring participants into their appointment for me because I've had difficulty, right? So that's what we mean also about community care. It's a team effort. You don't have to work at the TRC to be part of the work that we're doing. We are going to integrate the mental health, the medical, the social services, that full wraparound care. Again, like Dr. Louis is saying, it's really kind of a holistic, whole person approach. As we've talked about, we're addressing those clinical case management needs, the medical needs, the legal needs, the financial needs, housing, whatever comes back up for us. And that could look like a lot of different unique things. The culturally responsive services, you've heard Dr. Louis say the word like cultural humility. It is our goal to really provide services, make people feel comfortable with the people they're receiving services from. Okay, and evidence-based. So basically that means that there's science behind some of the things that we're implementing that can suggest that it's helpful. It's not Dr. Louis and I's personal opinion that this is just like really going to help you because we like doing it with people. There's data and evidence behind that these things can be helpful to you in reducing some of those symptoms. Okay,
Next slide, please.
next slide.
I'll take that one. So we are fully aware, as one person stated earlier, how about the barriers to care in terms of the stigma? How do you get people to engage? And I believe we've answered that question by how we engage, how we show up in spaces for people, significantly remove the stigma so that people can engage with us effectively. Next slide, please. Now, when we're talking about the engagement, right, how we track the information, how we provide a level of consistency in terms of how we reach out to people. We believe that individuals who have dealt with traumatic experiences, in order for you to engage effectively, you have to build that trust. And we do not take that lightly. We do not bring individuals in and have a long list of forms for them to complete or assessments for them to complete. We engage with people in a way that we can see them, hear them, and understand them. And the assessments, they are there. We have to complete them, but they are not the primary concern. We focus on engaging with the individuals first, get to know them before we proceed with those measures, those assessments that will help us to establish a baseline for services. Next slide, please. And as we stated, we meet with individuals wherever they are, the hospital, community, wherever they are is exactly where we meet with them. We don't have to spend so much time here because I believe we've covered those factors we have on the slide. What I want to bring to your attention is our core values, right? So our core values of CARE, and CARE, C-A-R-E is an acronym. We have it in the one pager we have here. So our core value, the very first one is cultural humility. The second core value is agility. Agility means simply we are extremely flexible, and we talked about the notion of flexibility. Wherever you need us, that's where we'll be. Respect. We not only respect the individual, we respect their culture, and we respect what they tell us the experience is, right? We do not focus on what other individuals, let's say if something happens in the community and law enforcement has one narrative about what happened with that child who was killed, but the mother says another story. We believe the mother, because in order for you to engage with people effectively, you have to believe their narrative, their experience is the experience. And certainly empathy is a primary focus of everything that we do. Empathy means that I'm able to feel with you, even if your experience is different than my experience. Next slide, please. We talked about all these aspects of the services, the clinical case management aspect of the services. We help individuals to apply for victim compensation benefits. Many people are not aware of such thing being in existence. Not only we educate them, but we certainly help them to apply for those benefits. We do a lot of linkages. Individuals like you can certainly refer potential participants to us, and depending on the roles that you play in the community, you might also help with the linkages. If you know someone in the community who perhaps has access to resources related to housing, we can certainly partner with you to ensure that we meet the needs of those individuals. We do a lot of advocacy, but we also bring other individuals into the space to do legal advocacy, especially when we are dealing with survivors of domestic violence. Next slide, please. So we receive our referrals from literally everyone and anyone, including yourself. So part of having this conversation with you today is not only to inform you on our existence in the community, to let you know what we do and the whys really behind what we do, but to invite you to bring this knowledge back into your network, your friends, your family, the people you worship with, the people you play with, the people you pray with, and give them an opportunity to access those services. Because as we shared with you earlier, unprocessed trauma is extremely expensive. And our goal is to reduce the implications for unprocessed traumas by providing services timely and effectively. So send those people our way, and we'll do the best that we can to engage with them from a very empathetic perspective. Next slide, please. Go ahead.
Okay, so like I kind of touched on earlier, the TRC really does call for a multidisciplinary, culturally diverse staff that can look like social workers, as we are here today in the room, marriage and family therapists, it could be a psychologist, a psychiatrist, case managers, peer support. I know some of the other TRCs are staffed a little bit differently and the composition looks a little bit different. So that's all the people who could be on the team. Next slide, please. So here's some of the services, the concrete things that we provide, right? Crisis debriefing and crisis intervention. That speaks to your earlier question about when there's a shooting in the community, you guys give us a call. Okay, the individual trauma-focused psychotherapy. 16 sessions is what our program covers initially. However, we don't just stop at 16. When the work still, if there's more work to be done, we're going to continue. We're going to renew you for another 16 sessions, okay? And you can stop whenever, right? You have self-determination. You don't have to be here. It's your choice. All right. We take a strengths-based approach with an emphasis on skill building. As Dr. Louis said, we see the person in their environment, we see them for who they are, and we build on the things that they're already good at, right? We all go through struggles, we all have hard times, but we all inherently have things that we are good at or that we have strengths in. And that's the perspective Dr. Louis and I, the TRC model, come from. We will also offer, medication management within this service. So people who need psychiatric medication also have the ability to be treated in that way, and family work.
Absolutely. Next slide, please. This slide helps you to understand the level of efficacy of the model. As we stated earlier, individuals who do not receive timely and effective services, they are not able to recover and thrive. But when individuals receive those services, not only they can recover, but they can actually grow from traumatic experiences. That's what we call post-traumatic growth. After trauma, people can actually grow if they receive services. So this slide, which I believe you all have, gives you the statistics about how individuals can recover, the percentage of their recovery. Next slide, please. We do not do things because they look good or they sound good. As we shared earlier, we do things based on evidence, right? So upon entry, we use standardized measures, but we use those measures with a great deal of cultural humility, meaning those measures are often not created for the individuals whom we serve. So we use their culture to inform how we administer those standardized measures. At 8 weeks, we re-administer those measures again so that we can evaluate the effectiveness of the intervention and certainly tweak the intervention if there is a need to do that. And we certainly re-administer those measures at the time of termination, meaning once we're discharging the participant, we administer those measures and we compare the intake measure, the mid-intervention measure with the termination measure to really evaluate whether or not the intervention was effective. Next slide, please.
I'm sorry, I gotta look to, excuse me.
Again, this is a summary. This is a summary of the core elements of the model. Everybody's welcome, so refer those participants to us. Next slide, please. This slide helps you to understand how many TRCs are there in the states, United States. We have about 51 trauma recovery centers in 12 states. We are one of the very few TRC in New York City. And although there are 4 trauma recovery centers in New York City, JCC-GCI TRC is the only operating trauma recovery center with participants who are receiving services day in and day out. So thank you for your attention. Thank you for the engagement. And we're looking forward to continue to engage with you all.
Thank you. Thank you for coming. Sharing all that good information with us.
Thank you for having us.
We will. Definitely.
We have our business cards, we have program literature.
We'll actually do that as well.
Yes.
No questions.
So who sponsors this program? Do you get federal funds or local funds, like from municipality?
Yes. Yes.
Okay. And then,
Thank you.
I'm also wondering if you work with Adult Protective Services, APS.
Not directly, but certainly indirectly. If there is a need for us to reach out and create that linkage, we will definitely be more than happy to do that. We haven't had a situation where we had to reach out, but that is definitely not off the table. In the future, if there's any future steps. I know we are running time. You guys have our contact information. You have our email address. If you have any questions related to the TRC and services, please feel free to reach out. So we'll be more than happy to engage with you or anybody in your immediate community who might need our services. Thank you for your hospitality. Thank you for having us.
Thank you for sharing that wonderful information with us.
Thank you.
and being so kind to our community as well. Highly appreciative.
Thank you.
And it's something that's badly needed, trust me.
Thank you. I know you guys have business to talk about, so we will
Yeah.
politely excuse ourselves. So you can take your
Yeah,
business.
and then the staff has to go home too. Yeah.
Thank you.
Thank you very much. So they can get back in the morning, right?
Are you adjourning the meeting? Excuse me.
What, with Ms. Fuentes,
Yes.
I think y'all sent me an email, we supposed to have met up from Marlboro. So she was here, two birds in one stone, I don't make up the presentation.
Can we meet tomorrow?
Okay, cause I'm gonna, email you, all right?
Pleasure meeting you.
Okay,
Thank you so much.
all right,
Thank
thank
you.
you.
Thank you, guys. We'll see you next time.
Okay,
Thank
take
you.
care.
Take care.
We're still, meeting is still going on, correct?
Huh?
We're still continuing the meeting,
No,
correct?
the meeting is.
Oh, you're adjourning,
it's
so we have to,
adjourned?
we have to adjourn, you have to adjourn the meeting.
To adjourn the meeting,
Yes, I'm saying, if you'd like to adjourn.
Waiting for them.
yeah,
Because we have people, on Zoom still, we're still. in the
Yeah.
meeting. Just so you're aware, that's all, okay.
so I adjourn the meeting.
Yeah.
Did you have
At
old
this time,
business?
we've had our guests, who shared a lot of information with us, and hopefully everyone take it back to their area and share it with the community, because definitely there's a lot of people in Coney Island can utilize the information that they have. So I want to thank everyone for coming. Thanks for your input and questions asked. It only broaden our perspective, and if the program works out, it would be wonderful for this community who needs it badly. So are there any other comments or suggestions or?
Good, thank you.
The only thing I think we must put a time limit onto people when they come for presentation, because it's easily to, the time can just go, and if a person know they have, when it's not just talking about this group, we're talking about anyone that comes, but I believe in fairness. If you have a slide or want to show, people might want to ask a question, maybe you might just want to go the first 30 minutes or 20 minutes to show your slides, however you want to, or you might want to do the introduction, but you want to have a time span in which things happen and which we get out at a decent time, because we have staff and people around the
15-minute
table work and have
presentations are
other
good.
things to do as well. So, our thing is, let's try to make our meetings on time, get on time, schedule our visitors on time, and get out on time. Thank you very much.
Thank you.
I want to make a move that we
Have a
close
good night,
the
everyone.
meeting. Did somebody say? Oh, that's it.
Thank goodness, I was gonna